What I'd like to tackle now is the conundrum of congestive heart failure, often more of a symptom that our patients present with that has many different causes and many different presentations. The important thing is it's considered whenever you have somebody who's a little more dyspneic and short of breath. When you think of congestive heart failure, think about it a few different ways. One, ask yourself, is it from the heart's inability to pump enough blood to keep up with the demands of the tissues? What are the associated comorbidities, the antecedents, triggers, mediators, or what aspect of the matrix might be involved? And we see these comorbidities all the time in our patients with congestive heart failure. So I see congestive heart failure as a symptom. But then you have to ask yourself, is congestive heart failure, is it a structure dysfunction? And is it based on energy dysfunction? So when you hear rails, when you see somebody having increased shortness of breath, you have to ask yourself, is this right-sided, left-sided failure? What type of heart failure is it? Just to call it congestive heart failure is like saying you have the fever. You have to look for what the root cause of it is. Let's talk a little bit about energy. When you look at about energy metabolic dysfunction, this was brought forward really well in an eloquent article in many years ago, New England Journal of Medicine, where they really outline there are real issues with substrate utilization, think adequate fatty acid, glucose utilization. There's issues with oxidative phosphorylation dysfunction. Well, we check this all the time, don't we, when we check organic acid tests? But what's interesting in this is you start seeing that there's increase in certain proteins, for example, an increase in uncoupling protein. Well, you don't want to increase in uncoupling protein when it comes to oxidative phosphorylation, because then you don't get production of ATP as well. Or it can be really a dysfunction in the high energy phosphate metabolism, and all these markers decrease. Here's the deal. When you go from New York Heart Association class 1 to class 4, you're getting up to a 40 to 60% drop in ATP levels in the cardiomyocyte. The cardiomyocyte that may have 5,000 mitochondria. So when I see somebody with congestive heart failure, the first thing I think about is energy metabolism. Well, you have to ask yourself, how well in congestive heart failure, how well is their ejection fraction? Is it their ejection fraction decreased because you have a weakened heart muscle? Or is the ejection fraction decreased because it's a stiff heart muscle? And what we're going to see in COVID patients or in people who have viral cardiomyopathies is the increased fibrosis. Increased fibrosis leads to increased failure because of diastolic dysfunction. On echo, you can see diastolic dysfunction. And when I see diastolic dysfunction in the right heart, I think about energy inadequacy. So when you think about energy inadequacy, you go over to the energy node, and in this very busy matrix that outlines all the different aspects of what we think about in our cardiometabolic matrix, you can go through the energy node and think, can I check those different items in my patient? Can I check their organic acid tests? Can I look at their echo? Can I tell on echo whether they have a restrictive or a weak heart muscle? And then you get a clue of how you might begin to address congestive heart failure in your patient. When you start looking at congestive heart failure, you can find in the literature almost all aspects and entries on this matrix that can impact congestive heart failure, but they're mainly in the structural integrity node, the transport node, and the energy node. So if you even start there in your patient with congestive heart failure, you're going to help them get better. The diagnosis by the Framingham criteria is you need to have two major or one major and two minor criteria. So look at this list. These are very familiar in your patients who have congestive heart failure. Often they can be subtle findings before they're obvious findings. So it's the things you can pick up on physical exam that would suggest that they are going into congestive heart failure. For most of our patients, weight change with associated shortness of breath is one of the key findings. So what are some of the functional medicine management aspects of congestive heart failure? Let's go into that a little bit. Well, you can start with their lifestyle. Stress management, we know when they have increased sympathetic tone, increased stress, not that anybody has had this during the last year with all the changes that have happened, the increased heart rate from your epinephrine or norepinephrine, your stress drivers, in its own right, increases the requirement for energy. And if you can't make that as well, then stress can lead to increased congestive heart failure. Weight loss is a modifiable lifestyle component that we know if you're not carrying as much weight, there's not as much demand on your heart. Smoking cessations, we can go into a whole talk about that. Blood pressure management. If your heart is having to push against smaller pipes, it requires more energy. Glucose management, glucotoxicity, mitochondrial toxicity, mitochondrial insufficiency. Gradually increasing the strength of the heart gets flabby and out of shape, much like the rest of our muscles can get flabby and out of shape if we don't rehab them appropriately. People have sleep apnea, guess what? There's increased association CHF. Optimizing magnesium levels, check a magnesium level so you have a reference level at which to supplement to. And really anything else that helps coronary artery disease. These are the 5 areas at the bottom of the matrix that we can concentrate on. And they are a very easy starting point for your patients with congestive heart failure. Your heart uses about 9% of your body energy per unit time. How often do we think about the components in our ATP production in our heart, and what are some of the things that can upregulate that? Let's go through a couple of them. One of them is having adequacy in CoQ10. You know, we can check a CoQ10 level as one of our biomarkers. With congestive heart failure, we want, well, for healthy levels, we want the CoQ10 to be above 2, but ideally closer to 3.5. So there are plenty of studies that have shown that when you supplement CoQ10 in someone with congestive heart failure in the 200, 300 milligram per day dosing, that you can actually move somebody from New York Heart Association 3 to New York Heart Association 2 if mitochondrial dysfunction or energy inadequacy, ATP inadequacy, is the cause. Think about that. By adding the CoQ10, you can move somebody from a New York Heart Association 3 to 2, which is revolutionary in life for people. So all my patients, if they have CHF, I would give that a therapeutic trial. CoQ10 is really high in the mitochondrial myocardium. Think of the number of mitochondria that are involved in each cardiomyocyte. So there are a lot of reasons that CoQ10 is important to augment, and it's a little hard unless you eat a lot of veal or a lot of buffalo heart to get enough CoQ10. Most of my patients aren't interested in eating that much buffalo heart. Think about the role of thiamine. Thiamine is so key moving from glycolysis into the citric acid cycle. It's one of the key vitamins in that pyruvate decarboxylase enzyme pathway. We know just by adding thiamine in your patients with CHF that it helps convert and move energy from glycolysis into into acetyl-CoA so it can be used in a citric acid cycle. It also improves diuresis and ejection fraction. So thiamine is also a kind of a go-to when it comes to somebody with CHF. Here's one we don't often think about. Taurine is not officially an amino acid, but taurine is equimolar in all tissue. It is a transfer molecule, sulfur versus nitrogen as your main component in your carboxyl system. So taurine is derived from cysteine, which of course is sulfur-rich, comes from sulfur-rich vegetables. In people with CHF, the dosing of up to 6 grams a day divided dosing has been used to treat heart failure in Japan. It's an antioxidant. It helps protect the cardiomyocyte from calcium overload. It's a good antiarrhythmic, which ties into some of the other talks that we've had in our course here. And it promotes natriuresis or diuresis, which we want to help the patients get the fluid off. And it also reduces the actions on norepinephrine and angiotensin II. So taurine is also one of those things. You can really try to upregulate it with cysteine in your diet, but you often have to supplement. The last one we're going to go through is L-carnitine. No brainer here as part of the carnitine shuttle to move free fatty acids through beta oxidation into the mitochondria for energy. When you start looking at metabolic cardiology, carnitine, L-carnitine, magnesium, taurine, CoQ10 are all key in improving myocardiocyte function. So to kind of close out here, in congestive heart failure, think about shifting the diet from a sodium-rich to a potassium-richer diet. We think about limiting fluid in New York Heart Association 3 or 4. We think about really following daily weights. Remember, alcohol is a mitochondrial toxin, and we're trying to increase energy. Think about all the antioxidants in your phytonutrient-rich foods that are so key to help improve mitochondrial function. Circling back around, we want to give CoQ10. We want to consider carnitine. You can check carnitine levels in the bloodstream and see where you're at. I know there's some worry about taking higher doses of carnitine for TMAO, but I'll just say, and Dr. Elliman talks about this, but TMAO is one of those things I think about dysbiosis. I'm not going to sacrifice energy metabolism by dropping out carnitine that's required in patients with CHF. I'm going to think about adjusting the microbiome. You're going to think about fish oil for all the anti-inflammatory and components of fish oil, but also it makes the heart membrane, the cardiomyocyte membranes, far more flexible. Think about adequacy of magnesium, not only as a cofactor, but it helps with insulin resistance. And then, of course, thiamine in your B complex. To take a step back, if you're not getting improvement from those, circle back around and think about testosterone or growth hormone. If your patient's testosterone levels are low, there's some data that improving the testosterone level improves muscle strength, exercise capacity in people with CHF. Circle back around and think about their hemoglobin A1C. Are they having more insulin resistance and glucotoxicity? Then go upstream of testosterone. What helps your body make testosterone or triggers testosterone? It's part of the whole pituitary growth hormone gonadal axis. And so there have been some studies on improving congestive heart failure, giving growth hormone, or addressing the androgenic axis. We know that congestive heart failure is helped with intermittent fasting. It can be helped with a ketogenic food plan or the MitoFood plan. But what you have to do there is look at it in the context of lipid changes. So anytime we have somebody with congestive heart failure and we're putting them on a ketogenic diet, we will go ahead and follow along with advanced lipids. Thank you very much for listening to this intervention talk on congestive heart failure. And by applying some of these simple interventions, your patients will do better, their ejection fractions should improve, and they will have a more liberated life. Thank you.